Let me just start recording. Okay. Sorry for the delay, everyone. My name is Brian. I'm one of the musculoskeletal radiologists and filling in last minute. Yeah, tried to get a little bit too fancy with my tech setup in my home office. Anyways, if you haven't already, go to polev.com and join this lecture. Please use your full name first and last when you're joining so we can track your responses. So technically these are going to be graded, but don't stress about it. I'll give you guys about another 15, 20 seconds. All right, let's get started. All right, so let's do a practice question. Just let me know your level of training. All right, sounds good. So mostly MS3s here, I guess rising MS3s. Great. And then what state were you born in? And this is just to get you used to the clicking on an image portion of this. So mostly Utah, some NorCal, oh, a lot of Idaho. Great. Someone's from somewhere in the Pacific Ocean. Okay. Oh, okay, no longer. There we go. All right, good. I think we're all ready. So our lecture today is on X-rays, but specifically some of the ways that they're limited and some specific situations where they can be used pertaining to MSK radiology. So question number one, this is for a grade. There is a correct answer. Have you or have you not watched Back to the Future, but be honest? It looks like we've got 21 people other than me today. So waiting on one response. Remember, these are graded. All right. So let's see the results. Show responses. Okay, so 20% of you have not seen Back to the Future. So just a heads up, this lecture is going to be very confusing for you. All right. So outline for today's lecture. We're going to start with a mini intro, talk about the benefits and limitations of X-rays, talk about some of the alternative imaging modalities like CT, MRI, and ultrasound, talk about the complementary role of X-rays. So when X-rays can help in conjunction with one of these other modalities. And then we'll introduce the ACR appropriateness criteria, which many of you probably have already heard of, and then we'll wrap up. So how are X-rays acquired? X-rays are acquired by having this machine and a person, and the machine shoots X-rays towards the person, and it's read out by this little detector. And anywhere you have something in the body that's very dense and is going to absorb a lot of X-rays, then that is going to show up as bright on the X-ray. So for example, if you're shooting the X-rays at this person's arm, when the X-ray hits the bone, it'll show up as bright because the bone blocks a lot of the X-rays. And the air around the arm is going to show up as black because it's not blocking any of the X-rays. And we have a lot of different ways of acquiring X-rays. This is like your standard upright chest CT, where the X-ray emitter is far away from the patient. Then here you have them on a table. This is more like a gastrointestinal setup. And then here you have a portable unit that can be used anywhere, which is becoming a lot more useful now during COVID times. So what can we see on X-rays? Basically, we can see different densities. So if you get this reference and you're interested, you're probably in MS3, but if you can't wait to move on, you're probably in MS4. So which of the following are not visible on X-rays? All right, a couple more. All right, there we go. All right, so looks like we've got a couple different things. So we'll talk about this. So what can we see on X-rays? So basically, you can see things of different density, right? So things on the left of the screen are less dense, and things on the right of the screen are more dense. So over here, you can see you have a knee X-ray, you can see bone, soft tissue, whatever. This is all normal. And then you have all these sort of black areas here, okay? And this is a patient who had an open laceration. So basically, their muscle is communicating with air, which we can see posterior to the knee. So yeah, we can see air on X-rays. It's very commonly used in patients who have concern for infection. So when you get an X-ray and you're looking for subcutaneous gas, that's one thing to look for. Okay. Then moving on to the next most dense thing. So it's gray over here, but you can see that it's a little bit more dense than the air outside of the patient, and it's less dense than the muscle that it's in. So this is fat. And this is a patient who has a intramuscular lipoma. You can see that it's the same density as the subcutaneous fat that's just underneath the skin. Moving up, you can see this patient who has first toe pain, and they have this bony erosion here, and then they have this rounded soft tissue density on top of this. You can see that they have other erosions here in the second toe. So this is a patient with an inflammatory arthropathy, or actually with gout. Okay. And then with gout, you know that you have soft tissue deposition, including calcification, but this is actually non-calcified. This is a big non-calcified tophus. So this is soft tissue density. So the prior question was kind of a somewhat of a trick question, but basically fluid and muscle and other soft tissues are all going to be the same density. So we can see both of those on X-ray. Moving on, this is a patient who has a fracture, and the fracture is splitting this bone in two, so we can see that really well with X-ray. Everyone knows that. And then last of all, the most dense, you can see metal, and this is a patient with a hip prosthesis. You can see how uniformly dense this is compared to the adjacent bone. So remember, X-ray shows us different densities, and things that are less dense are going to look more black. Things that are more dense are going to look more bright. And I should mention, if anyone has any questions at any time, just interrupt. Okay, so X-rays. What are some advantages that X-rays confer over other imaging modalities? Great. Cheap is a good one. Fast, very true. Quick, also true. Cheap, agree. All right, so most people are going down the fast and cheap um, pathway. Okay, so great. So let's talk about both of those things. There's a lot of other ones that X-rays can do. Portable's a great one. Okay, so let's talk about some of these. So some of the benefits of X-ray, and this is in contradistinction to all these products which are still unavailable during COVID times. So they're very easy to acquire, okay? Both meaning that it's well tolerated by the patient and it's very fast. So it takes on the order of minutes from door to door and takes on the order of seconds in terms of just actually acquiring the image. It's widely available. Basically, we talk about resource limited settings all the time. And in places that don't have access to CT or MRI, they definitely have access to X-ray. And last of all, it's very cheap. So important point, X-rays are usually the first study that you're going to order in almost every situation. And then I think the bottom's cut off a little bit, but just know what you're ordering. Special views may be crucial in making the diagnosis, and we'll go over some areas where that's true. So it's not all good news. X-rays definitely have some limitations. So for one, you're getting basically just a static image. There's no information over time or position. And then findings can be obscured by overlapping structures. If you put something metal on top of something fat, you're only going to see the metal because the metal is going to absorb all those X-rays. It has limited soft tissue contrast. So we talked about like 5 things that you can see on X-ray, but you can't really tell the difference between different types of muscles, and seeing the interface between 2 things can be pretty hard sometimes. It normally sees bone really well, but if you have an older patient who has low bone mineral density, those bones aren't going to absorb as much X-ray, so they're going to look darker, and it can be hard to see things like fracture or infection. It doesn't give you any functional information, so like a PET tells you which things are metabolically active. X-rays just don't give you that. And then it is associated with radiation, but it's really negligible. Like the radiology societies have actually gone away from recommending things like radiation shields in the setting of X-ray. So it's not something you have to worry about, but patients will be worried about. So let's go through some examples. Okay, so I meant to take some of these out, but I will tell you there's no abnormality here. So don't worry about it. Let's see where some people thought there was. Okay, good. Nobody's responded yet. Oh, somebody clicked on the heart. The heart is normal, but let's go over what we can't see. So basically, this is a normal looking X-ray, but what I wanted to point out is that here you can see this person's arm is here, which means their shoulder is here, their clavicle on the lateral chest X-ray. So there's a lot of overlapping structures which prevent you from being able to really see the thoracic spine well, okay? So when we go, this patient still had back pain, so we went to MRI, and you can see that they have a pretty nasty compression fracture at T1, okay? So you have height loss on this T1 weighted image of the cervical spine, and then you have marrow edema in the bone, which tells you that there's an acute fracture. There's a little bit of retropulsion, meaning that some of the bone has moved backwards into the, or towards the spinal canal, and it's compressing the spinal cord right here. So this is an example of a T1 vertebral body compression fracture. There's a lot of places in the body that aren't imaged well by X-ray, especially when patients are larger, because there's a lot of tissue it has to penetrate. All right. Here's another patient. And I'll just activate responses. We've got a 40-year-old woman with right foot pain after a minor injury. See if you can see where the abnormality is. It's pretty not obvious. Let's say. Okay. Someone put a symbol over or clicked on this area called Kager's fat pad. So there is a little bit of stranding here in the fat, which is normal, but it can be abnormal in people who have like an Achilles tendon problem. Someone put clicked on the plantar calcaneal spur, basically like a heel spur, which you can see sometimes with plantar fasciitis. A lot of people clicked over here on the sesamoid, which is a normal accessory bone in our bodies. It helps with flexing our toe here. I don't see anything abnormal here over by the 5th toe, but a lot of people did click in the region of the 1st and 2nd tarsometatarsal joints. So I think they're leading towards something called a Lisfranc injury, which I think is a good guess. I'll point out what nobody clicked on is the soft tissue here, which is probably about 5 times thicker than it should be. And that's a sign that they had some injury in this area, okay? So don't forget, bone seen really well on X-ray, but don't forget to look at the soft tissues. So let's see what else we can do. One thing I'll point out about this is this foot is kind of hanging out in midair. So this is somebody who's lying down. And when we're lying down, a lot of our lower extremity isn't imaged in an anatomic position because normally we're standing. Okay, so one thing you can do is you can get a weight-bearing radiograph. Okay, so this patient is actually standing up. You can see this little pad underneath them. And then if you're worried about a Lisfranc injury, what you're worried about is this ligament here that connects this bone to that bone being torn or injured. Okay, and then this area looks a little bit wide, but when they're standing up, you can see that it really opens up. Okay, so it makes it a lot easier to see the injury. So even though we can't see the ligament itself, this widening of this space tells us that that's torn. The diagnosis was not made on this radiograph, and it was made correctly on this x-ray. And this is a really important one that you don't want to miss because it can progress onto a lot of midfoot stability, and then basically your foot can collapse entirely. So Lisfranc ligament complex injury, but more important, know the importance of getting weight-bearing studies in the lower extremities. Okay, here's another case. This one you actually can see the abnormality, but it's really subtle. So it's a 14-year-old boy with right hip pain. You got your frontal view and a lateral view. So I'll give everyone a little minute here. I didn't realize there's a timer. Oh, it's not working. Okay. Let's see what people came up with. Okay. People still guessing? Good. So a lot of people are clicking over here in the general region of the right hip. I guess that was a helpful hint. But most of the symbols that I see are on structures that are normal. Okay. So this is your femoral head. This is your acetabulum, and all these little divots. Those are normal anatomic structures. Someone here clicked on the greater trochanter. That's this structure. That's normal. That's what your glute's attached to. This is the intertrochanteric region / lesser trochanter. This is normal. This is the hamstring origin or the ischial tuberosity. So this is a 14-year-old boy. So this is not going to be fused yet. That's normal. And that corresponds to this area here. You can see that there's some other areas that aren't fused, which are normal in the iliac crest. So what nobody pointed at was the correct answer. So what is actually abnormal is right here. Okay. So this is really, really subtle because it's overlapped by the patient's other leg. You can see his gluteal musculature here, and then the proximal thigh on the contralateral leg, and it's covering this bone, which you can't really tell that it's separate from the remainder of the pelvis. So really hard. So what you should do is you should get this different view. This is called a frog leg lateral, and this is called a cross table lateral. So this frog leg lateral is basically a different way of looking at the hip from the side. And when you do that, it becomes really obvious that there's this bone fragment that's separated from the adjacent ilium. Okay. So this is an avulsion fracture involving the anterior-inferior iliac spine. This is very common in kids. And the rectus femoris is part of your quadriceps muscle and attaches right here. Okay. So another limitation is inadequate views. So sometimes, you'll order a 2 view of the hip and you just expect to get the right thing. But we can give you many different types of views of the hip. So it can be really helpful, especially when you're looking for a specific clinical question or an answer to a clinical question, to know what you're ordering so you can get the right study to answer the right question. Okay. 70-year-old guy with right hip pain. Click on the abnormality. Ten more seconds. All right, what do we got? Okay, so a lot of people clicking on the hip joint. A lot of people clicking in the intertrochanteric region. So in these patients, clicking on the hip is a good guess. Osteoarthritis is really common in this age group, but he has a pretty nice looking joint for 70. I would take this hit at any age. And then a lot of people clicked in the intertrochanteric region, so between the lesser and the greater trochanter of the femur, another really common place for people to have hip pain due to a fracture in this age group, but this guy doesn't have anything. So I can't see any abnormality on this patient. The one thing that I notice, which is not exactly abnormal, is that his bones look a little bit paper thin, meaning that these little white lines, those are the bony trabeculae. Those are what create support for your bone. And they're in contradistinction to the cortex of the bone, the outside layer, which is very thick and bright. So there's less of these than you see normally, which means that the bone is going to look a little bit blacker than normal. Okay, so he's osteoporotic. So in patients that are osteoporotic, a lot of times you can't see non-displaced fractures because when you have a fracture, it kind of breaks these little bony trabeculae, and that's what makes the fracture pop up. So in this patient population, you're going to want to get an MRI. And on the MRI, it becomes very obvious that he has a non-displaced fracture going from the greater trochanter into the femoral neck. And then on the STIR sequence, which is just like a T2 where fluid is bright, you can see that there's a lot of marrow edema around this, so it's acute. So this is somebody with a femoral neck fracture, very important. You might know some on this data, but patients with hip fractures are expected to die within a year. I think something like 50% of patients will die within a year. So it's really important to find these fractures quickly and fix them quickly because the bed rest and the recovery, that leads to a lot of debilitation, which leads to mortality. So in patients who don't have a lot of bone stock, namely older patients, you can miss a fracture pretty easily, and it's important to consider getting an MRI in those situations. Okay, next case, 13-year-old kid, right wrist pain after a fall onto an outstretched hand, so foosh. A lot of common fractures that happen in kids when they fall onto an outstretched hand. Let's see if you can find the one. Okay, 5 more seconds. All right, everyone is clicking in high yield areas. I like it. Okay, so distal radius, very common. Ulnar styloid, very common. Scaphoid, very common. Trapezium and trapezoid, not quite so common. Same with pisiform, triquetrum, not quite as common, but still could happen. So yeah, some of these answers are right, but I will say this fracture is very subtle. Okay, so one thing I'll point out is that this looks a little bit funny, and it's not something that I expect a non-radiologist to see, and it's not something that I expect a lot of radiologists to see. It's one of those things where you might question it because you know this is a fracture that you don't want to miss. So again, we can go to our friend MRI, and then it becomes super obvious that there's something abnormal here. So normal bone on a T1 weighted sequence should look bright, okay? So all this is bright because there's bone marrow, and bone marrow has a lot of fat, and fat is bright on MRI, kind of like this subcutaneous fat, okay? And then there's this whole area where the marrow is kind of dark, and then there's this line that kind of goes through it, okay? And then on the T2 weighted sequence, you can see that there's a lot of edema in the distal pole and the scaphoid. There's a little bit in the distal radius as well, so it probably has a little contusion there, very common after falling onto the hand. But this is a non-displaced scaphoid fracture. So non-displaced scaphoid or fractures are really hard to see on X-ray. And there are some locations, like the scaphoid, where it's even harder to see because it's a curved kind of three-dimensional structure. It's curved both in the medial lateral plane, going this way, and then in the anteroposterior plane. So it looks kind of like a seahorse to me. but it can be really hard to see fractures here on MRI. Also a very important fracture. Some of these tend not to heal, and then this area can actually die off because the blood supply is cut off in these fractures, and they can get really bad arthritis, and you don't want that in a 14-year-old kid who's probably got, more than half a century of his life ahead of him. So limitation, some fractures just can't be seen very well on X-ray. Okay, 28-year-old man with right shoulder pain, click on the abnormality, and let's see your short-term recall. Basically, a prior case might help you with one of these, or finding the abnormality here. And 10 more seconds. All right, what do we got? All right, all over the place. I like it. So I'll tell you right now, bones are normal. So anyone who clicked on a bone is wrong. People who are clicking in this area are generally, there is a little bit of something here, but I don't think you can really make that call on this X-ray because there's a tendon, basically your rotator cuff, that comes in through here. Okay. To all the people who clicked in these soft tissues above the bone, that's very astute. This area is where the deltoid muscle is, but it's a little too thick. Okay. The other thing I would point out is normally you have a sharp interface between structures of different densities. So between bone and soft tissue, you can see very clearly where the bone ends and the soft tissue starts. Normally you can see that too where the muscle ends and the fat starts. But in this patient, you can see that the fat is kind of hazy. Okay, so this guy has some swelling overlying his shoulder. Okay, and now that our responses are gone, you can see that that's where the interface should be between muscle and fat, and you can see it's kind of indistinct. So this is an IV drug user, so you're going to be worried about infection. Okay, so let's move on to MRI, and you can see that this patient, their bones are normal on this stir sequence. If they were abnormal, we expect them to be bright. Okay, but there's all this edema overlying the muscles. Okay, and some of it extending into the muscle as well. This is probably your trapezius here, and then your deltoid's coming down here. And then on the post contrast, you can see that there's all this rim enhancement, okay? And then surrounding soft tissue enhancement. Again, the bone looks normal and the joint looks normal. So in somebody with a fluid collection, a soft tissue in their soft tissues with rim enhancement, those are all buzzwords for an abscess, okay? So this guy was an IV drug user. You're worried about septic arthritis, you're worried about osteomyelitis, but you're also worried about soft tissue abscesses, okay? And then the reason we can't see any of this, we can see the swelling, but we can't see that there's actually a rim enhancing fluid collection, is because X-ray doesn't provide you enough differentiation between soft tissues of different type, namely fluid and muscle, to be able to make this diagnosis.
I have a question.
Yeah.
Is it even recommended to get an X-ray with suspicion of like an abscess or septic arthritis?
Yes, very much so, and that's a great question. We're going to talk about this more later on in the lecture, but basically, X-rays are going to be the first line for almost every single indication, especially if you're getting MRI. Because I think it's a lot easier to see the big picture here. Like if you saw a bone erosion on this X-ray, it would be pretty obvious. On MRI, even though abnormalities are easily seen, a lot of different types of abnormalities can look exactly the same on MRI. So it's good to give you sort of a bird's eye view of what's going on with the patient. Like we said before, it's cheap and fast, so it's not really going to increase patient costs or time in the ER very much to get an X-ray. A lot of times we'll wheel them to X-ray and then immediately bring them to MRI, so it doesn't really add any time. And then the last part is you want to know if there's anything crazy in the area that's going to make it hard to interpret your MRI. So one thing that's really hard to evaluate is air. Okay, Air is a lot easier to see on an X-ray than it is on an MRI, and if there's a lot of air in the X-ray, it may make the MRI look very confusing. And then another thing is metal. So if somebody has a replacement or prior fracture hardware, you're going to want to know that before you put them in the scanner, not necessarily because it's not safe. It's more so that all the artifacts that you get from the metal on an MRI, you can sort of use the X-ray to help you figure out what's going on. It's a good question. We're going to talk a lot more about that. All right, moving on. 32-year-old woman with foreign body sensation after hiking. She thinks she might have stepped on something. Five more seconds here. Okay. All right, so lots of different guesses here. I will point out she thought she stepped on something. It's probably a good guess to click on something on the bottom of the foot. But, you know, sometimes people can't localize things well. Her bones look pretty normal to me. A lot of people clicked on the midfoot here. These are all normal joints. They look kind of funny because of the way they overlap. You can see here, you have this sort of stair step pattern, so it can be easy to mistake this for something abnormal. Okay, but honestly, I don't see anything. This looks like a normal 32-year-old foot. Okay, so we're zooming in on the area where she feels something. She feels it around the first MTP joint, and I still don't see anything like holding up a magnifying glass to it, okay? So a lot of different options to look for foreign bodies afterwards. CT, MRI, ultrasound. MRI is kind of a big gun for looking for a foreign body. CT is not bad, but CT is the same technology as X-ray, so if you don't see it well on X-ray, there's a good chance you won't see it well on CT. So ultrasound is the way I would go. Ultrasound allows you to basically put the image the patient exactly where they're feeling symptoms, okay? And the other thing is it can see things that aren't dense on X-ray, like, for example, wood is a common foreign body that people get while hiking under their skin, and ultrasound is really good at looking at that. So here's the ultrasound. It's really funny because I think ultrasound makes things look enormous. So it looks like I don't know, Wolverine left a claw in this patient's plantar foot. Okay, but look at the scale here. This thing is about a centimeter and a half, so less than half an inch. And this is the first metatarsal, so that's this bone. This is the first proximal phalanx, which you can't really see. This is just a general area of where it is, so that's this bone. So just underneath that bone on the bottom of the foot, you can see that there's this sharp object, okay? And then this sort of rim of dark signal around it. That's what we call a foreign body reaction. Basically, our bodies attempt to wall off this thing that's not supposed to be under our skin. And this is a power Doppler image, basically where you see increased color, or where you see colors, that's where blood flow is, okay? So there's a little bit of inflammation around this thing. So this patient stepped on a cactus. So she has a retained cactus spine. Everyone told her she was crazy. She had seen many providers over the past 3 months, and they were like, there's nothing. And then we put this ultrasound on there, and you can see it. So limitations of X-rays, not good for non-radiopaque things. So like unless it's metal or glass, a lot of times it's hard to see. And you should still get an X-ray before you're getting this, just again for planning purposes. But a lot of times if you don't see anything, moving on to ultrasound is the next step. Okay, one of the easier X-rays to find the abnormality, 17-year-old boy with right knee pain. Not to put any pressure on you guys. Okay, give you a little less time on this one. All right, let's see what you came out with. All right, so these are all good guesses, okay? I'll tell you this is the correct answer. There's a little bony spicule that's pointing out from the posterior tibia. Okay. A lot of you clicked over here. That can be abnormal in a 17-year-old kid, but this is your tibial tuberosity. That's where your patellar tendon attaches, and sometimes it takes a while for it to fuse. And these are the people when this is abnormal. That's called Osgood-Schlatter disease, which you probably have heard of. And then back here, this is where your gastrocnemius muscle attaches. This can look a little bit irregular in kids too, and also the physis is coming across here and hasn't completely fused yet. So that's actually normal. So this is what's abnormal. Okay. So they have this bone sticking out from the posterior tibia. That's called an osteochondroma. So if you just had the x-ray, that's all you think this was. Okay. But this patient was having more pain, and there's a lot of structures that pass by through your posterior knee. So they went on to a CTA, okay, which is basically a CT that is focused on looking at the blood vessels. And the blood vessels are going to be bright on a CTA. So this artery is your popliteal artery, okay, and it travels through the back of your knee. And as it's crossing this bone structure, as it's crossing the osteochondroma, you can see that the lumen of the vessel is really narrow, okay? And then we did this 3D reconstruction, which lets you see the caliber of the vessel, and you can see how narrow it gets. These are all your blood vessels here. So this is somebody who had popliteal artery stenosis, but it was caused by this osteochondroma, okay? Just this sort of benign structure is causing narrowing of this artery, and that can lead to some claudication in your lower extremity, okay? So if we just had the x-ray, we would only see this. But now, since we got the CT with contrast, you can see a lot more structures, namely your vascular structures. So the inability to give contrast or intravenous contrast on radiographs is another limitation. 55-year-old man with right wrist pain. This one's another one where you have a decent shot at finding the abnormality. Remember, short-term recall, use some of the skills you've learned from prior cases. I'll give you 5 more seconds here. All right. Very good. Okay. Lots of clicks over here. Scaphoid, good guess. This looks sort of lumpy. A lot of people look lumpy on this side of the wrist. Distal radius, that's normal physis. That's it's called a physeal scar. So basically, when our physis fuses after skeletal maturity, sometimes there's a little line that's left. Okay. But there's this. So there's this big ovoid soft tissue density on the radial side of the wrist. You can see it's like pushing the skin surface up. So looks like a tumor, right? But it's not. So this is a guy who had a recent catheterization for a cardiac issue. And so what they did was they did a radial artery puncture, and they fed the catheter through the radial artery up towards the heart. And this patient ended up getting an ultrasound, and you can see there's this really well circumscribed ovoid thing in the subcutaneous tissues, but it's right next to the radial artery. Okay. And on this color image, you can see that there's blood flow going through the artery, and some of it's actually going into this mass, okay? And then we actually got a video of it in real time. Oops. Let's go back one. And you can actually see that the blood is going into this mass, like this, you know, sort of geyser, okay? I'll watch that one more time because I think it's cool. Except it's not working. There we go. You can see the blood flow kind of erupting into this mass-like area. So this is actually a radial artery pseudoaneurysm. So this looks exactly like a tumor or a mass on X-ray, but when you get the next study, you can actually get real-time information. So if you just got the X-ray, you might tell the ordering provider that this is cancer, but it's actually just a vascular issue. And this also highlights that it's really important to know the clinical history when you're making these diagnoses. Okay, 56-year-old woman with left thigh pain. Tough one. I think this was called correctly by the radiologist, but this is pretty hard. I'll give you a little bit more time on this one. I want to see what you guys come up with. And apologies in advance because of my technical difficulties. We're going to go a little bit over today, but I don't think you have anything after this. And if you need to leave at 10, please feel free to do so. Okay, I think that's enough time. What do people come up with? So we're all over the map, right? There's this here is your sacroiliac joint. This here is the normal foramen in your sacrum. If you're clicking on the hip joint, yeah, they have a little bit of arthritis, but that's not what's going on. Okay. Lots of normal bony structures clicked on. This is normal fat in between muscles. So everyone is making some reasonable guesses, but not actually clicking on the actual abnormality. So the actual abnormality is right here. And I can barely tell that it's here, and I've been doing this for a while. So no shame in not seeing this at all. So you see here, this is where the joint capsule is, okay? And there's a muscle next to it, and because they're two things of different density, you can see this little line here, okay? And that's fat, okay? And there's a lot of areas where you can see fat in between normal structures. So like here, there's fat in between two muscles. Here, there's fat in between two muscles. Here, there's nothing, okay? This is super dense. Like I can't see through this at all, and I can't see the normal fat planes. Normally you have your adductors here, like your adductor magnus and longus. And since they're all layered on top of each other, you can normally see fat planes in between them. So we went on to MRI. Got a giant tumor here. This is a really bad tumor. This is something called a pleomorphic undifferentiated sarcoma. So you might not know a lot about sarcomas at this point in your training, but you probably know pleomorphic and undifferentiated and sarcoma are all bad things. So this is a really highly aggressive cancer with a very high mortality rate. Okay, and if you just got the X-ray, it would be really hard to tell that this mass was here. So you might give them a false negative. It's important to know your next stat. I think this is the last limitation case, 17-year-old male pitcher with right elbow pain. Anyone going to peds or family med is going to see a million of these. Okay. Hey, April, are you giving lecture after this? All right. Send me a message if you are.
Yeah, I think I am. I might be at the wrong time, but I think so.
Oh, okay. I apologize. I am going to go a little over because I had some technical difficulties at the beginning and started late. So probably going to go about 10 to 15 minutes long. I'll try to wrap it up quickly though.
Okay, no problem. Thanks.
Thanks, April. Okay, let's see what people have. Okay, so good guesses, especially people who clicked over here or over here. Okay, but more so people who clicked over here. So everyone's heard about tennis elbow, golfer's elbow, that kind of stuff. Those are just terms for medial and lateral epicondylitis. So yeah, pitchers can have those issues, but really the most common area where young male pitchers are going to have pain is going to be on the ulnar side of the elbow. Okay, everyone's maybe heard of Tommy John surgery, where they do ulnar collateral ligament reconstructions. Very common in baseball pitchers, and then in kids can be an issue as well. So I flipped the X-ray so we can really zoom in on the elbow joint, and there's a little bit of soft tissue swelling in this area. Okay, but you can't really see a whole lot. The bones look totally normal. So this patient went on to, so this is where the ulnar collateral ligament should be. So it's going from the end of the humerus towards this little point on the ulna. So we got an ultrasound, and what we did was we took the patient's elbow and tried to make a gap here. So basically we're pushing this side of the elbow to kind of stress the ulnar collateral ligament, okay? So here's your humerus, here's your ulna. This is where the ulnar collateral ligament should be, and this is your joint space. Okay, so we're putting that stress on there. You can see that we can make this joint space open up. Okay, one more time, I'll show you guys. So narrow, wide with stress. Okay, so basically the supportive structure that used to be here, namely your ulnar collateral ligament, is no longer working. So this is a ulnar collateral ligament tear. Okay, so x-rays are static examination. You can't do any sort of dynamic maneuvers to emulate physiologic stress. So when you throw a baseball, you're putting a lot of stress on this structure, which we can reproduce on ultrasound. So x-rays, static examination is a little bit limited. Okay, I think this is the last one. 10-year-old girl with hip pain. I won't tell you which side. Let's see if you guys can figure it out. I'll give you 15 seconds. Let's see what you got. Wow, I'm very impressed with whoever clicked right there. This was not easy, and I'm very impressed with the people clicking there and after I pointed this out. You can see that on this side, there's a little bit of lucency here, meaning it's less dense compared to the right side. Okay. Then now with the aerial, maybe it becomes a little bit easier to see. And then there's this kind of rim of sclerosis around it. So this is a patient who was having pain at night, got better with NSAIDs, and got an MRI. Still a little bit hard to see, except for the fact you can see all the edema around here. It's a little bit harder to pick up that there's a lesion right there. There's a lot of reactive changes in the joint. Then on CT, it becomes really obvious. There's this round lucency that's in the cortex with surrounding sclerosis. And then somebody put this probe in there, and this is something called an RF probe, or radio frequency ablation probe. And what they're doing is at the tip, it generates heat, and they're burning this lesion. Okay, so that's a treatment for something called an osteoid osteoma. You guys have probably heard about this at some point. Very common, or relatively common cause of pain in young people of unknown origin. And these things can be really irritating, but hard to see. So even though we saw it on the x-ray, you can't really use this x-ray for procedures because it's hard to localize in space exactly where this is. But on CT, you can do this in real time. You can do like a very low dose scan right through that area, and you can guide the probe into the right place. So x-ray is not best for providing procedural guidance.
Can I ask you a question about that? Mm-hmm. That hip joint looks kind of funny to me. Mm-hmm. Am I wrong?
On the MRI or on the X-ray?
On the X-ray.
Yeah. I think the hip joint looks pretty normal. I think part of why it looks abnormal is because the femoral head has not fused yet. So you saw the physis here in a 10-year-old. The hip joint is still developing, is what I'm saying. And then back here, there's another physis, which you can't see. Maybe you can see it a little bit better on the other hip. That's where the three bones of the acetabulum fuse. So your ilium, your pubic bone, and your ischium. Okay. So because those things are still open, the hip joint looks kind of funny.
Thank you.
Yeah, good question. Okay. All right, moving on. Alternative imaging modalities. So how much do you guys think an MRI costs? I don't know. I think this is activated. I thought this was a multiple choice question though. All right. So maybe this question isn't set up correctly. Oh, people are answering. Never mind. All right. Let's see what people put. $1,000, not a bad guess. Thousands of dollars, pretty pricey. $3,000. Okay, so everyone's going in sort of that $1,000 range. 12,000. 12,000 is pretty expensive. 50,000. That's like an entire hospital stay. 2-3 stacks. All right, I like it. Okay, so a lot of people are thinking in the thousands to tens of thousands of dollars. Okay. So let's take a look at how much MRI actually costs. $600 is actually a better guess than a lot of these, so very good. Okay. So lots of alternatives to X-ray. Okay, and this is sort of a generic chart showing some of the pros and cons. So X-rays are cheap. And you know what? We're going to go through all of these. In the interest of time, I'm going to skip through this slide. But I'll just point out that MRI costs about $700 to $1,200 according to this chart. If you're looking at Medicare numbers, that's probably a little bit less than that. But basically, MRI is expensive. Like, don't get me wrong. And these numbers don't necessarily reflect the cost that goes to the patient. But it's not in the grand scheme of things. Like if somebody's getting a hip replacement, that hospital stay is going to cost like $100,000. So in the grand scheme of things, MRI is not that expensive. Okay, but it is more expensive than CT, ultrasound, and X-ray. So let's go through some of our other options. So CT, it's fast, cheap, good at bone, but has some of the same limitations as X-ray. Specifically, a lot of people want to use it for infection or tumor. I don't often use it in these situations because they're not that sensitive. So here's somebody who has a tibial plateau fracture, much more obvious on CT. Here's somebody who has a femoral neck fracture, very not obvious on CT, but obvious on MRI. Okay, so CT is pretty good, but not as good as MRI in a lot of situations. So in musculoskeletal radiology, we use a lot of MRI. It's relatively expensive, but we went through some of those numbers, probably not as expensive as some people think. This patient has a mass here. It's a lot easier to see on the MRI. This is a patient with gout, so this is just a soft tissue tophus. And then we talk about how MRI isn't good for metal, but you can see that we can see this giant fluid collection around the hip in this patient with a hip replacement. So we're still pretty good at it if we know about it ahead of time. Ultrasound, it's good for focus examinations. Remember that foreign body. And it's really good for superficial structures. So here's somebody who has an Achilles tendon tear. So you can actually do a dynamic sequence when you're bending the patient's ankle, and you can see that there's this huge, nasty fluid gap where it's torn. And then here's where it's limited. This is a very large patient. We took a look at their shoulder with ultrasound, and it's really hard to see the difference between the fat, the muscle, and the rotator cuff tendon. And this is a comparison in a very thin patient. You can see this beautiful rotator cuff tendon separated from the deltoid muscle, separated from the subcutaneous fat. Nuclear medicine, important thing to remember is emits radiation and it reveals physiologic information. So this is a bone scan. This is somebody with this big lesion here. This is fibrous dysplasia. And then you can see that on this bone scan, so the tracer is going to go to where bone is turning over or active. So you can see that it's all hot, but there's also other areas in the rest of the leg that are also hot. So it gives you a bigger picture idea. This is a patient with a MET. It was resected and replaced with this prosthesis. But here you can see that there's a lot more soft tissue swelling in the side of the arm than there was back then. You get a PET, you can see metastatic disease everywhere. So this is just going where this uses labeled glucose. Glucose is going towards areas that are metabolically active, like tumors. And you can fuse these images with CT to get a PET CT, and that helps with tumor localization. All right, so what imaging study is best for evaluating a tumor? Let's see what you guys got. Oops. Didn't mean to show responses quite yet. I'll have you guys know that these questions are graded in the loosest sense of the word. Okay, PET-CT, MRI, both great guesses, but actually depends on the tumor is the most appropriate answer. All right. So this is just emphasizing how X-rays are complementary to other modalities. So they all have advantages and disadvantages, but we use a lot of them together to come to the right answer a lot of the time. So we're going to go over the complementary rule. We have this MRI of the elbow in somebody who had a mass, okay, or a palpable abnormality on exam. And you can see that there's this rounded thing here. You can see that as a low signal intensity rim, and it's really bright. So it looks like a tumor. But if you get an X-ray, you can see that there's this pretty benign looking ball of bone here, okay? So this highlights how MRI isn't quite as good at looking at the bone as an X-ray, and this gives you a really big picture idea of what's going on, okay? And this is something called myositis ossificans. It's a benign diagnosis. It happens in response to trauma. So if somebody like bumps their elbow, they can develop this thing which looks kind of scary on MRI, but the X-ray tells us it's totally normal. Here's another patient with all these masses in the back of their knee, okay? Then you go to X-ray, and you can see that they have all these round, lucent lesions throughout their skull, arm, pelvis, proximal or other arm. So lucent lesions everywhere. This is an elderly patient with multiple myeloma, and this tells you that these are related to amyloidosis, which goes hand in hand with multiple myeloma, okay? So this X-rays allowed us to image the entire body and get a big picture idea of what's going on, and then MRI lets us focus in on the area of concern. Okay, so sometimes I should use X-ray because it's complementary. Sometimes I shouldn't because it's limited. How do I know what to order? So ACR appropriateness criteria, which you guys have probably heard of. And we're going to fly through this. You guys can look at this on your own time, but basically the ACR is a radiologic organization that created a whole bunch of guidelines on what to order when. So in musculoskeletal, there's all these different topics: wrist trauma, hip pain, ankle, foot, knee, and so on. And it gives you, you know, prose form of the rationale for ordering certain things, the evidence in support or against ordering things, their references, and some other information. All appropriateness criteria will have the following two things. They'll have this, which says if it's green, it's usually the right study to order in most situations. If it's yellow, sometimes it's okay, and if it's red, it's usually not okay. And then it also gives you the relative radiation of each study, okay? So this is no radiation, this is a lot of radiation. So use an example, we got this 49-year-old woman. She's got diabetes. She's got right foot pain and swelling. She's got a draining ulcer. So you're worried about an infection, namely osteomyelitis. So here's a chart from an article talking about all your different options and all the different pros and cons. And that's sort of boiled down to you. Or actually, last question here. I'll give you 15 seconds to answer this because we're running out of time. All right, one more person. There we go. Okay. Oh, good. X-ray, most important study to order in almost every situation. And that's reflected by the appropriateness criteria. The only study you should order first in diabetes is an X-ray. Okay. So here's her X-ray. You can't really see a whole lot until you zoom in on the top of the toe here, and you can see that she's got a little soft tissue ulcer here, okay? And then that's the dressing over it. Okay, but I don't see any bony erosions or other things you would expect in osteomyelitis. So X-rays were negative, but you're still concerned about osteo. All right. People still thinking. All right. I think we're close enough. All right, MRI with and without contrast, very good guess. MRI without contrast, also a very good guess. A and B are usually appropriate. A lot of people with diabetes can't get intravenous contrast because of compromised kidney function. So really, A and B MRI with and without contrast can be appropriate. And there's a whole bunch of other things that may be appropriate on given the correct clinical situation. Let's say you're worried about osteomyelitis, but the patient has a pacemaker that's not MRI safe. A CT is a really reasonable alternative. Or let's say you just don't have access to MRI because you're in a resource-poor setting. A lot of these other things can be appropriate. So you see the soft tissue ulcer here, but a lot easier for me to see, at least on the x-ray. And this marrow here is all dark in signal compared to the normal bright signal. And then on this fluid sensitive, you can see that there's all this edema in that area. So this is a patient with acute osteomyelitis. Okay, I think this is the last question. Should I use ACR appropriateness criteria? This is graded. All right, 4 people are still unsure. 3 people, one more person isn't sure. All right, so I guess most of you know that you should use this if you're unsure what to order. Okay, so in summary, x-rays, order them first, but know their limitations. Know that x-rays can be complementary to other imaging modalities, and ACR appropriateness criteria can help you decide what to order in the future. All right, any questions? Great, April. Sorry for delaying your start, but I think you can take over now. Let me make you the, well, actually, I don't know if I can make you the presenter. Yeah,